Good afternoon and welcome back to our second part of our presentation and webinar today on community engagement. Our next presentation will be done by three amazing and wonderful colleagues. It'll be the Mapping Project, Mapping Children's Health Vulnerabilities and Opportunities. I am pleased to present my colleagues, Ms. Adrienne Nassel, Dr. Baker, and Dr. Oates, and their extensive bios and expertise are actually listed again on the link that you'll find actually in the link to the presentations. So without further ado, I'd like to turn this project over to my colleague.
Thank you, Dr. Cohen-Beasley. I'm Gabriella Oates, and you will hear from me very briefly. The majority of our presentation will be done by my colleagues, Dr. Baker and Adrienne Nassel. I will just set the stage for this work. In our presentation, we will tell you how we use both geographic and social science for pediatric emergency planning, specifically how we use this integration of sciences to visualize the geographic reach of the 10 hubs of the network in order to understand the patient populations served by the hubs, to identify populations that were not reached, and determine the vulnerabilities of key populations of interest. In our presentation, we will also focus on the strengths and opportunities of this approach that we used and how it can be used for future planning. This audience is very familiar with the concept of emergency planning. What I would like to add is our project made sure that in emergency planning, resources, information, and services are distributed not just based on convenience or geography, but based on need and other important considerations, and not just based on existing infrastructure or convenient geography. Our approach also recognizes that response to emergencies is very significantly shaped by non-medical factors. The family's income, language, their type of housing, their access to transportation, and this is what we're able to bring to the table. In terms of how we integrated our sciences, we combined spatial data with various social indicators on population level, so we can give the hubs a multidimensional understanding of who is served currently by the existing emergency systems, who is left out or who is underserved, and help them understand potentially why these gaps exist and how to close them. And now I will introduce my colleague Liz Baker, who will take you through the methods of this approach and show you an application of what we did.
Hello. So yes, what we wanted to do in this project includes visualizing the geographic reach of the 10 PPN hubs and see the extent that this coincides with the child population. This would allow us to identify the population not reached as well as those who are reached. In addition, we can overlay these maps with other factors that measure vulnerability, including the Social Vulnerability Index, which measures 4 distinct categories of disadvantage. This can highlight hotspots of need as well as with vulnerability. This information can be used for future planning, including simulating disaster events and identifying where surge support or mobile units are most needed. This can be used to build dashboards for real-time response coordination and support balanced resource allocation and investment. It also allows us to outline strengths and opportunities by mapping the existing PPN hub partners. We can also map out community-based organizations and trusted messengers and build out our outreach capacity. So this accumulated into our story maps. And I'm going to provide you with a few of the highlights from our story map for Alabama. We began by mapping the patients to the zip code. Darker colors mean more patients. As you can see, most come from central Alabama, but there is also a lot from the southeast area, specifically around Montgomery. We also examined areas that rely on children for care. For this, we examined the proportion of children in each zip code that were patients of Children's. From here, we were able to examine two unique use groups. The first one we call high volume areas. So this is where a lot of children's patient population come from. So what you see is 75% of all of the patients of Children of Alabama come from these areas. So that's high volume areas. There's also high usage areas. So these are areas that rely on Children's for care. This is places where a high proportion of the child population rely on Children's or are patients of Children. In Alabama, we use this cutoff as 12.5%. So 12.5% of the children in these zip codes were patients of Children's of Alabama. And now I'm going to hand it over to my colleague, Arian Nassau.
Hello. So while these visualizations, these map visualizations are invaluable for informing strategy and community engagement, they also bring forward a critical obligation, and that is balancing insight with responsibility, ensuring that our use of patient data adheres to HIPAA regulations and individual privacy standards. Our team here at UAB Children's works with geospatial patient data daily, and we walk the line of maintaining HIPAA compliance while retaining much needed granularity for research purposes of that data. The maps you have seen so far are derived, and that's a word that will come up again later, from the number of patients served by each hub, aggregated to the zip code in which each patient resides, and these are HIPAA compliant numbers. Because our responsibility is not just to understand the communities we serve, but also to protect the privacy of the individuals within them, which is critically important to maintaining patient trust. So this is a review of HIPAA compliance and the privacy rule, but I think I'll just move ahead to discuss de-identification. So PHI, just a quick overview, is personal or also known as protected health information, any individually identifiable health information consisting of things like demographic information, location, health conditions, and many others. So the goal is for us and for anyone utilizing patient data as well as geospatial patient data is to de-identify that data, or separate the identifiable information from the health information to ensure that there is a very low risk of re-identification. To do this, there are two main methods. The first is known as safe harbor, which many of you have probably heard of, and the second is expert determination. I'll start with the first. Safe harbor requires removal of 18 types of identifiers. These range from names, some of them being obvious identifiers and others a little less obvious. We have names, dates, anything from a birth date, admission date, discharge date, numbers such as telephone numbers, fax numbers, social security, even medical record numbers, and as well as any geographic subdivision smaller than a state. This includes a county, a city, a precinct, a congressional district, or a zip code. So once you remove those identifiers, there is no actual knowledge, residual information that can be identified about an individual. Now, this has been used historically, and there is an additional method known as expert determination. And so you're asking, well, you just said you use zip codes, and why is that? Why are you able to do that? Well, that is a great question. Thank you for asking. So what you do with expert determination is apply the statistical or scientific principles of an expert to minimize and really come up with the smallest risk possible that there could be a re-identification. And re-identification is the goal, that was what we do not want. Re-identification is simply the ability for an interested party to use reasonable effort to match details from a data set with additional details to come up with an identification of a person. With the advent of AI, the incredible speed of computer processing power that is continually growing, as well as the many, many data sets that are freely available to people, the risk for re-identification becomes higher. And so while these things such as a individual address per se, or maybe a fax number might not seem identifying, they can be once they are placed into a context of many different other pieces of information. You can think of it as your Sunday morning Sudoku game when you're sitting with your coffee or your tea, Sudoku being the logic-based number placement puzzle game that sort of tests your powers of deduction and pattern recognition. So if you have a fax number and then you add to it other pieces of information and you search on a fax number, and you can start adding together these different pieces like you would in a Sudoku puzzle, and eventually end up with some identifying pieces of information that fit together just like a puzzle would. So expert determination works with the idea that there is a person with appropriate knowledge and experience with generally accepted statistical and scientific principles for rendering the information not individually identifiable. And there are a number of pieces that go into expert determination. One of them being the numerator rule, and then there's the denominator rule, where there is not any set federal or national standard for how many individuals or patients or incidents of a disease that is acceptable to be used in a mapping situation. So what we do is we go by, for example, CDC Wonder, the CDC databases, and what they decided is that anything between 0 and 10 incidents or patients is considered to be too small to be shown on a map. And then the National Environmental Public Health Tracking says that that goes anywhere from 0 to less than 6. And then others look from 0 to less than 11. And so you can see that there is a range with mostly anywhere from 10 to 15 incidents being the number that you don't want to go under. And then the denominator is the needed number of general population in a geographic area. Let's say a zip code or a county would be anywhere from 250,000 up from 5,000. So it really just depends on how many incidents you have or patients and the size of the area that you want to show spatially or map on your map as to how much risk you're willing to accept and utilize to keep any type of re-identification from occurring. So determining risk varies based on the zip code itself and how the zip code is combined with other variables, as I was saying, the Sudoku puzzle. So you have the date of birth as an example, if that was available, and the sex, and a 5-digit zip code. And if you had those 3 things, and this is just an example showing you how re-identification could occur, and that those together, if you piece them together, would be 50% of the US residents you could identify with those 3 unique pieces of information that you could cobble together, possibly, if you were so inclined. And then also, we're showing that if you utilized a 3-digit zip code instead of a 5-digit zip code, that you could only possibly re-identify 0.04% of the US of US residents based on that, or the patients based on utilizing that less granular level of geography. So what we do is to meet the numerator and the denominator conditions, and from that, we are able to then come up with an incredibly low risk. But remember that I said to the word derived would come into play. These maps that we are utilizing are derived from the actual numerator of, and so they do not represent the number of patients in any zip code that is shown. They're actually derived numbers. So it is the high usage number derived from statistical methods by Dr. Baker, as well as the high usage. And that is how we have mapped them. So we're actually mapping the statistical analysis rather than the individual numbers themselves. And so these two methods, the safe harbor and the expert determination, are utilized. But you can see with the safe harbor, if we removed the geographic, if we only utilized the state level or the state of residence of individuals, we would not have much potential to truly understand our patient populations. And so we follow as much, removing as many identifiers as possible, and then we move over to the expert determination method, and we make sure we have a certain number of individuals or incidence of disease in our geographic location of interest, and then we look at the general population and make sure that applies in the denominator rule, and then we do our determination of risk and bringing those two together. And then we also have the statistical analysis that we do that erases any knowledge of what the numerator was in the first place. And that is how we successfully remove the possibility of re-identification of any patients in these zip codes that we are mapping, and maintaining thus our patient trust and our ability to do this work that is very important for informing strategy and community engagement. So that leads us into improved opportunity. The impact of these maps ensures that high-need populations are not overlooked in emergency responses. It allows us to do more robust data-driven decisions, such as funding, staffing, and infrastructure decisions, which are guided by this spatial and demographic data and the social determinants of health. And it also allows for more decision-based preparedness and accountability, helping the PPN hubs demonstrate reach and identify priorities to stakeholders. And future directions for this project are to integrate community assets and map those locations to identify areas that are lacking key resources and that perhaps could be targeted to increase their amount of resources in relation to the usage of that area by the Children's of Alabama hub patient population. The future direction are also to use participatory methods, focus groups, and surveys to understand community trust and capacity, and to support opportunity-centered resource allocations and investment. And so that brings us to the end of our presentation. And questions for the three of us?
So we have a question of what SDOH factors are you able to map? So there are many different factors. The Social Vulnerability Index relies on data that's collected from both the US Census as well as the EPA. And this includes things like environmental burden, as well as factors like poverty, housing burden, low education, low insurance. There are several different indices that exist. We focused on the social vulnerability index because this one was created specifically to identify vulnerable groups of people in the event of a natural disaster or a pandemic, which went nicely with the Pediatric Pandemic Network.
There's another question. What are you able to measure within the vulnerability index? So the social vulnerability index includes anywhere between 15 and 17 variables, depending on the year of a couple of different versions. These variables are grouped into 4 domains. One domain that's being measured is socioeconomic status, derived from variables such as income, education, property values, etc. The other domain is housing and transportation, access to vehicles, as well as a type of housing, for example, like mobile homes or institutional homes. A third domain in the social vulnerability index is household composition, measuring disability, number of children, a number of adults over the age of 65, as well as those elderly taking care of single parent households. And the last domain is minority status and language, which captures some of the racial and ethnic diversity and composition of the area. And there is another question. Arian, would you like to answer this one? The question is, how might a community obtain this GIS information if they don't have experts where they live? As well as another question, how might communities use this information? I will just start with saying that as Arian pointed out in future directions, we are going to be mapping out community assets and resources. So if at the point when this is available on a dashboard, for example, a community member or community-based organization or community stakeholder may be able to see, okay, what is available or not available in their area. For example, access to transportation, or a broadband access, which would affect, for example, availability of services such as telehealth, and any other community assets that are of importance to the community. You do not need to have access to a GIS expert in the community, because the idea is that this is all mapped out for the 10 hubs and their spokes. So anybody in the catchment area of the hub, any community member or organization should be able to use this information, see it visualized graphically on a dashboard, or in any other form and they can turn on and off the appropriate layers. I'll actually hand it off to Arian. This is again future directions. That's not something that's currently live or existing, but the maps that we demonstrated, that we showed, like kind of demonstrate the opportunity of this approach. Do you want to add anything?
Thank you, Gabriella. No, I think actually that you summed that up. This information, it's not something that needs to be, the maps themselves can be utilized by anyone in a community that is given the information, like you were saying, through a dashboard. It's designed to be easy to understand through the maps and to be easily interpreted by a range of individuals. For example, language differences, our accessibility issues, the maps sort of transcend that and allow you to locate yourself and understand what is around you in the environment.